A 25-year-old man comes to the physician for shortness of breath while climbing stairs. He is 193 centimeters, 6 feet 3 inches tall, and weighs 72 kilograms, 159 pounds. BMI is 19.3. His arms and fingers are long and thin. The physician schedules an echocardiogram for further evaluation. This patient most likely has an abnormality related to which of the following? Choice A, collagen. Choice B, elastin. Choice C, methionine synthase. Choice D, retigene. Choice E, X chromosome non-disjunction. I'll wait 5 seconds and answer the question. This is Marfan syndrome, autosomal dominant fibrillin 1 gene abnormality that leads to various manifestations, most classically the very tall and very thin body shape with long arms and arachnodactyly, which just means very long fingers. Pectus carinatum or excavatum is pretty typical, but that's not the case in this patient at least. Scoliosis is found sometimes, and hypermobile joints can also be found. Subluxation of the lens upwards is one of those buzzy findings you might hear about sometimes, but you typically shouldn't need to rely on that to be able to diagnose Marfan syndrome or differentiate it from the other Marfanoid habitus conditions. And of course here you're scheduling the patient for an echocardiogram because aortic aneurysm is a huge risk in Marfan syndrome patients. Aortic dissection is the most common cause of death among Marfan syndrome patients. But let's dig into the other answer choices here, because it's often the case that I think people can get these Marfanoid habitus conditions mixed up a bit in their head, and I want to try to clarify that. Most notably, choice A, collagen, is talking about ehler-danlos syndrome. Some people get confused between Ehlers-Danlos and Marfan syndrome especially. You should not be mixing these two up. Ehlers-Danlos can also present with Marfanoid habitus, but it's not universal among patients. But even if they give you one with Marfanoid habitus, the most standout thing you should know about Ehlers-Danlos is the hypermobility and hyperextensible skin. So basically their skin can be very stretchy. They'll have a history of tissue fragility and impeded wound healing. Basically, the stretchy skin plus the impaired wound healing are a lot more standout for Ehlers-Danlos. Whereas with Marfan syndrome, you should be looking for the very tall, very long arms and long fingers. And if I give you upward subluxation of the lens, this is kind of a gimme, right? That's Marfan syndrome. People like memorizing that buzzy finding because it's one of those things where it's like, oh, it's subluxed upwards, which means you're looking up at how tall the Marfan syndrome patients are. Like I said, you shouldn't rely on that as a crutch. And another warning I want to give you is retinal detachment is not the same thing as upward subluxation of the lens. Both of these conditions actually have an increased risk of having retinal detachment, which is totally different, so don't mix them up. And again, Ehlers-Danlos is collagen, whereas Marfan syndrome is elastin. And just as a side note here, choice A, collagen here, technically it could also refer to things like osteogenesis imperfecta, but that's obviously not in the conversation with us right now because there's no reason you would mix that up with any of these. I mean, if you do, I'd be a little bit concerned. So anyway, choice C, methionine synthase. This is one of those obscure enzyme deficiencies that some of you might have studied for homocystinuria. Homocystinuria is usually caused by cystathione beta synthase deficiency. If it's an enzyme deficiency at all, obviously the first thing you think of is like a B9 or B12 deficiency causing homocysteine buildup. But if you have the congenital enzyme deficiency causing homocystinuria, that can also present with Marfanoid body habitus. It also would have intellectual impairment. Fair skin is something that happens, and blood clots is what causes death in these patients a lot. It also has downward subluxation of the lens, which is one of those buzzy things people like memorizing because it's like, oh, Marfan syndrome, you look up for upward subluxation, and homocystinuria, it's because they're peeing, so you get downward subluxation. Like I said, do not rely on stuff like this as a crutch. It's nice to get it as a gimme, but it's unlikely that they'll give it to you because it's too easy. As far as this patient goes, I mean, he just doesn't have any of the symptoms related to homocystinuria, right? And if he had homocystinuria, he would manifest much earlier than age 25. Choice D, Rett gene. Obviously, I'm referring to MEN type 2B here, which can also present with Marfanoid body habitus. But of course, it is one of those autosomal dominant tumor syndromes. So this patient, if I was trying to tell you that he has ME in type 2B, he would present with a history of some kind of cancer. Medullary thyroid cancer, pheochromocytoma, mucosal neuromas are classic. So even if I didn't give you the mucosal neuromas, I mean, I would tell you something like, oh, he's coming in with pounding headaches that come and go to represent pheochromocytoma. Something like that, right? So he doesn't have any of those symptoms, as I said. Choice E, X chromosome non-destruction. This is just a distractor. Klinefelter syndrome patients are sometimes described as being very tall. But again, he doesn't have any of the symptoms. No hypogonadism, no gynecomastia. Infertility is what they typically like to present to you. So just going back to it, Marfanoid body habitus conditions, most of them are not easy to mix up. I think the ones people tend to mix up sometimes is ehler-danlos with Marfan syndrome. And just remember, ehler-danlos is collagen, and you get the stretchy skin as well as impaired wound healing. Whereas with Marfan syndrome, like in this patient, it's a fibrillin-1 gene disorder that results in faulty elastin. And they like giving you long arms and arachnodactyly. I hope you found this video helpful. I'll see you in the next one.